acute injuries and overuse injuries. About acute injuries, the most common race injuries are contusion, abrasion, blister, and strains. And the running is the sport where we have the more injury occurs. The serious injuries are rare, with no cycling falls and collision. That now are more with the new rule of cycling, and contusion at swim start, particularly in the head. The situation is different in long distance and Ironman. As I say, not here in Ironman events, the hydratation and exhaustion were reported much higher than trauma and orthopedic complaints. The most common size of acute injuries are the ankle, foot, and knee for all the people, and lower limb muscle strains or foot laceration occurring during water or pitch cases in the swim leg or the running in the transition area. Like other endurance sports, particularly running, the 80-85% of triathlon injuries can be ascribed to overuse. And we know that approximately 3 times as many athletes are partly affected by overuse as are affected by acute injury. This is mechanics where there are the balance between the adaptation and the damage of the muscle tendon. Running has been the most commonly reported action associated with injuries in triathletes. From 58 to 71 of injuries are caused by running. And running, followed by cycling and then swimming, is commonly held responsible for the overuse injuries, specifically for knee, lower back, and shoulder injuries, respectively. We know that the athlete most at risk are foreign swimmer and cyclists, since they lack of running experience and their lack of muscle elasticity. An expression of hydratation is the high percentage of injuries that occur in the first year of triathlon practice, maybe for the insufficient attention given to the development of running technical ability. The most injuries overuse injuries in triathlon occur on the lower extremity. We know that we have intrinsic and extrinsic cause, particularly HSC pronation, callus foot with decreased pronation, varus valgus knee, dysplasia patella, asymmetry of the lower legs, increased age, particularly high impact running style, previous injuries and sporting background. We have to study also the temperature with the problem cold, wind, rain, the shoes, poor old or very new shoes, poor training equipment, running surface because it's different to run in a flat surface or in a regular surface, ill running, poor warm-up procedure, lack of stretching, and insufficient care of muscle. The main cause of running injuries can be epileptic triathlon, particularly anatomical factor, biomechanics of swimming, cycling, running, training and error, particularly too much too soon, to change suddenly the volume or the intensity of the training surface, shoes, equipment, and the transition. Transition is particularly important to study is the transition cycle run T2. As said earlier, the transition for cycling to running is usually the phase of the race in which the greater performance of elite triathletes is seen compared to the middle-level athletes due to minor muscular fatigue, minor exercise expense, and from the immediate organizing of correct running mechanics. In T2, we have the change from concentric muscular contraction to change 1, and from unload cycle phase to the load state of running. It is an extremely delicate phase for the triathlon. We have the inability of the locomotor system to dissipate lower force by the lower limb and result in the transmission of stress to the lower sacral region and to the knee. We know that during cycling, sitting in a flexed position and for a long period has been shown to increase intradiscal pressure, predisposing to low back pain. With longer biking, more time is required to regain the neuromuscular and elastic efficiency indispensable for proper running style. A tiny leg exists after cycling before the neuromuscular and elastic efficiency required for the optimal running technique can reach its optimal level. It's for all of this intent that transition cycling run is a period of particular risk of knee and lower back injuries. And maybe the cycle and run training may exert cumulative stress influence on the risk of lower back injuries. Iliotibial pain syndrome is one of the most common injuries in triathletes, particularly in age group triathletes. We have to study the transition cycle run, and normally it causes a combination of factors, particularly training error, run slowly in intensive training, the training surface, hill running on road roads, the poor running technical ability, particularly anti-pattern style, and the combination of anatomical variant of the lower extremity with improper cycle fit or the improper cycle fit, for example, a certain to height, and the anatomical factor, large and asymmetry of the lower leg. We have to study also the background of the athletes, because the athletes that have a sporting background in swimming normally tend to have a weak gluteus medius, and the triathletes fatigued after the bike, after the cycle fraction, are prone to increased tight adduction and internal rotation and distance, leading to an increased valgus vector and decay. The triathletes that have sporting background in cycling tend to be too tight knee flexor, tensorfascial lateral, and iliotibial band. It's for all of this situation that iliotibial band have a great impingement on the lateral epicondyle of the femur, especially during foot contact, when maximum deceleration absorbs acceleration force. But in the last year we have also other injuries, particularly at the Achilles tendon and strength fracture, that occur more in the elite athletes. This is for the high training in running, because to run the final 10K with performance on the international level, it is necessary to do training sections that are similar to those carried out by many distance runners. In track we have the problem of thermal injuries, hyperthermia and hypothermia. The training competition of climates can cause many problems for triathletes, particularly when we have high temperature and humidity, at time, at exertion and stroke. Exercise associated lapse is the most common reason that athletes are treated in the medical tank following a training event. Also, rhabdomyolysis is frequent after field race, and the association of rhabdomyolysis with stroke, dehydration, hyperthermia may cause some